For intestinal obstruction, the definition of this disorder is a blockage by preventing normal passage of contents through the intestines. The types of intestinal obstruction include a mechanical and a non-mechanical. For the mechanical intestinal obstruction, this includes tumors, adhesions, volvulus, and hernias. For non-mechanical, this includes a paralytic ileus after surgery, hypokalemia, and in older adults, higher risk for volvulus due to a decreased muscle tone. Signs and symptoms. Signs and symptoms include, for the upper tract, sharp abdominal pain, vomiting, minimal distension. For the lower tract, this includes a gradual onset severe distension, fecal vomiting. For treatment for intestinal obstruction includes a decompression with an NG tube. Surgery is also needed for unresolved cases, and you also want to monitor the fluid and electrolyte balance, pain management, and monitor their abdominal girth. Hernias. So a hernia is a protrusion of the intestine through the abdominal wall. Types of hernias include ventral, which is an epigastric and an umbilical, and an inguinal and a femoral. Okay, so 3 types. Ventral including the epigastric and the umbilical, and the inguinal and the femoral. Some symptoms for hernias include a swelling or a lump in the abdomen / groin area, discomfort, or pain. For treatment, herniotherapy, surgical repair, herniorrhaphy, okay, which is a surgical repair, and a laparoscopic or an open surgery with a mesh reinforcement. For nursing care for hernia repair, for post-operative care, monitor pain control, because the person may be in pain after having this hernia removed. Avoid heavy lifting or activities that increase intra-abdominal pressure. As we know, lifting or increased pressure can increase the risk for hernias. Teach your patient to support the site when coughing or sneezing so that they don't push the hernia back out or add any more extra pressure to the abdomen. And you're going to want to monitor for signs of complications such as infection or a recurrence of a hernia. Moving along, next we have bowel ischemia. The definition of bowel ischemia is when bowel ischemia occurs when the blood supply in the intestines is insufficient. The causes of bowel ischemia include low blood flow, which is hypovolemia, which can lead to shock, and a gradual narrowing / occlusion of the vessels. Diffuse atherosclerotic disease of mesenteric vessels. Very difficult words. Acute versus chronic. This can be an acute or chronic condition depending on the duration of the onset of symptoms. Signs and symptoms and diagnosis. This includes a sudden severe abdominal pain, nausea, vomiting, diarrhea, abdominal cramps, tender abdomen, guarding your abdomen, and a minimum or absent of bowel sounds when you auscultate the abdomen. Diagnosis includes elevated white blood cell counts. When you get your CBC and they check the numbers of your white blood cells, if the white blood cell count is elevated, this is a sign of bowel ischemia. A CT scan or angiography or magnetic resonance angiography, MRI pretty much. CT scans or MRIs is pretty much how they're going to diagnose the bowel ischemias. For treatment, make sure this patient is NPO, nothing by mouth. They will need an NG tube, which will relieve distension. Hydration, which would include some IV fluids, and monitor the output of their urine. Some medications would include an IV heparin and a thrombolytic therapy. Surgery may be required if the bowel tissue is necrotic. So if you let that tissue die, then surgery for bowel ischemia may be needed. Next, we have inflammatory bowel disease, which is different from irritable bowel syndrome. So, inflammatory bowel disease includes ulcerative colitis and Crohn's disease. Ulcerative colitis, also known as UC, and Crohn's disease. Those are the two actual inflammatory bowel diseases, not inflammatory bowel syndromes. Different. The syndromes were the diarrhea and the constipation, while your diseases is the ulcerative colitis and the Crohn's disease. These are genetic predispositions and more common amongst the Jewish population. Smoking increases the risk for Crohn's disease, but not for ulcerative colitis. Signs and symptoms. This includes a diarrhea, which is often bloody, abdominal cramping, and weight loss. More bloody stools in ulcerative colitis, and a fever in malaise and cramping. Diagnosis includes a colonoscopy, flexible sigmoidoscopy, and a barial enema and a stool analysis. Treatment for irritable bowel disease. Diet. You're going to want them on a low-fat diet, a low-fiber diet, high protein, and small, frequent meals. Medications would include antidiarrheals, sulfasalazines, biologic agents, immunosuppressants such as methotrexate, and azathioprine. Surgical options include an ileostomy, a cock pouch, and an ileoanal anastomosis for UC. So drugs for IBD, these would include your sulfasalazines, your mesalamines, osalazine, bausilazide, the disododium. The actions of these drugs reduces the inflammation by suppressing prostaglandin synthesis. Some nursing implications include regular blood cell counts needed due to the risk of agranulocytosis and anemia. You want to teach the patient to caution with sunlight and use a non-oral contraception. Report rash or sensitivity. Infliximab, okay, so the classification of this is a monoclonal antibody. It neutralizes and to reduce the inflammation in Crohn's disease. It decreases the inflammatory cell infiltration. For nursing implications, you'd want to administer an IV over 2 hours, repeating dosing at 2 weeks and then every 8 weeks. You want to monitor for an anaphylactic reaction. Initial side effects include an increased diarrhea, and patients should report nausea, vomiting, or rash. It is very important to not breastfeed during this therapy. Antispasmodic medications. The common drugs include your dicloclamine hydrochloride, which is your Bentel, and all of these other listed meds that y'all can see that they are very long names that I'm not about to say and continuously keep trying to pronounce. The actions of these antispasmodic medications is to block acetylcholines to reduce smooth muscle spasm and motility, and also inhibits gastric acid secretion. You want to teach your patient to take 30 to 60 minutes before meals. Drink 2,500 to 3,000 milliliters of fluid daily. It may cause a dry mouth. This is why you want to drink all these fluids. May make you dizzy or may make you have blurred vision. You want to report rash or skin eruptions to your provider because this could indicate an adverse reaction and they may need to switch some things up. These are pretty much some of the main differences between ulcerative colitis and Crohn's disease. So with UC, the mucosa is the only part infected. With Crohn's disease, you have full thickness in the intestine, which is usually the small intestine. So for UC, it always involves the rectum. And like I said, for Crohn's disease, it's mostly the small intestine. For UC, diarrhea with blood. For Crohn's disease, intermittent diarrhea with cramping, no blood. Some complications include a hemorrhage and cancer for UC. For Crohn's disease, complications include fistulas and obstructions. I just find it crazy how UC could possibly lead to hemorrhage and cancer, and Crohn's disease just leaves you with fistulas and obstructions. Both diseases are still irritable to the bowel and to the stomach, but one can lead to cancer and one doesn't. One contains blood in the stool, one doesn't. One affects the whole rectum, one is only the small intestine. So when you're thinking about ulcerative colitis and Crohn's disease, these are some of the main differences that you can use to differentiate between the two diseases. Appendicitis. Now let's talk about the appendix. Appendicitis, this is an inflammation of the appendix. This is caused by a bacterial infection due to the obstruction of the appendix. This happens when you have trapped fecal material left inside the appendix. Some signs and diagnoses. This includes pain at the McBurney's point, which is at the lower right quadrant of the abdomen, right here. Also includes nausea, vomiting, muscle guarding, fever, elevated white blood cell counts. It is diagnosed by a CT scan or an ultrasound for pregnant women and children. For treatment, you may have a surgical removal of an appendectomy, and that's just pretty much taking the entire appendix out. For pre-operative, before this procedure, you want to put the patient on NPO, nothing by mouth, IV fluids, and antibiotics. For post-operative care, pain. The patient may be in a lot of pain, so you're going to want a pain management. It could be some type of pain medication or just whatever you can do to help the patient not be in so much pain. You also want to monitor for infections. Don't need any infections after surgery. And you also want to monitor for mobility. If we can get the patient up, moving as fast as possible, we won't have them immobile, which could lead to a list of other complications, constipation being one of them. For a safety alert, do not use heat for abdominal pain. You don't want to use heat for an abdominal pain for the appendix because this could cause the vessels to dilate and bring more blood to the appendix. And if you are bringing more blood to the appendix, that's going to irritate it more and possibly cause it to rupture a lot faster. So, no heat. If anything, cold, but definitely no heat. Nursing diagnosis is in management for this. Like I said, monitor the pain due to inflammation, fluid deficit due to diarrhea, and altered nutrition from the diarrhea because you're flushing out all of your electrolytes and flushing out all of your, the things that your body needs, and you're having a malabsorption issue because you're flushing everything out with the diarrhea. For nursing goals, we are going to want to control the pain, restore fluid balance, improve nutrition, monitor stools, check for internal bleeding, and assess electrolytes. All of the things we are going to want to monitor for appendicitis.